You look taller than me.
I'm wearing my tall shoes, but I am sitting down.
Well, it seems improbable, too. People won't know I'm a little taller than you.
So I carry myself with authority.
That's true. You are wearing your judge's garb today, so.
My space judge.
Yeah. Cool. Well, I'm Dr. Jonas Schwartz, here with Dr. Beverly Gray. This is Outlawed.
This is Outlawed. Go into the classroom to teach you all about abortion, everything you ever wanted to know. Maybe not everything you ever wanted to know, but most of it. All right. So before we started this podcast, we were giving a lot of talks all across the institution, and we lovingly refer to our talks as the Bev and Jonas show, which is how we came up with this idea of a podcast, because we were sharing, I think, important information.
Just a one-ring circus, though.
Yeah.
Two-ring circus? I don't know.
I don't know. Maybe I was in downtown Durham the other night. We were walking around, and at one of the venues downtown, they were having a party, and they had this woman that was doing like a one-woman trapeze act as kind of the entertainment. She was just in the corner, and no one was watching her. It was really fascinating.
Wow, that sounds scary.
I wanted to know, how do we get invited to that party?
Yeah. We need to be invited to cooler parties. All right.
Or maybe if we have a party, we could have a trapeze act. What do you think? Okay. All right. So this is Abortion 101.
It's like when you wanted to incorporate the jumping out of the plane analogy.
I arguably have a lot of good analogies.
Yeah. Yes, you do. Not all of them are home runs. All right.
Fine. All right. This is our lecture about abortion. The first part of the lecture is really talking about the epidemiology of abortion and the fact that abortion is common. So how many people in the U.S. have abortions, Jonas?
I actually don't know the number. It's around 100,000 a year, right?
Around 1 million a year.
Yep, that too.
And actually, since Dobbs...
170,000 traveled, so obviously it was over,
5 times
so 1 in 5, yeah. Okay.
And since Dobbs, it's actually become more common. People think, okay, you have this ban on abortions, then people are going to have fewer abortions. Wrong. They actually have more.
It does highlight, though, that commonness issue. So, what means common to other people? First of all, there are different ways to measure common, right?
Yeah.
So what this slide shows is that it's a very common experience in someone's reproductive life to have an abortion, as 1 in 4 or 1 in 5 people will have one by the time they reach menopause. But then the other measure of common would be how many people have it per year.
Right. So a little bit more than 1 million. And worldwide, those numbers are the same. So whether there are restrictions or not, roughly 1 in 4 people of reproductive capacity will have had an abortion by the time they reach menopause.
And around 1 in 5 pregnancies end in abortion, and around 1 in 5 pregnancies, or a little less than that, end in miscarriage. So pretty similar to miscarriage in that respect. What this slide shows us, or what I see from it, is it's about who has abortions, right? And what I see from this is that abortion cuts across race, it cuts across income, it cuts across religion, and age. There are a few important distinctions in terms of who has abortions. Disproportionately young people. More importantly, 3/4 of people who have abortions are low income or living under the poverty line. And because the economics of abortion are such a limiting factor, that's a really important detail about the patients that we're caring for and who's at risk of having an unwanted or unintended pregnancy.
And then the other things that we like to point out is that roughly 60% of people are already parents, so folks already have kids, and about 62% of people are religiously affiliated. So that's, kind of is counter to the narrative around who seeks abortion.
Abortion disproportionately occurs very early in pregnancy. And that's why, we've talked about, it's such a frustrating myth when people talk about abortions later in pregnancy, which I would define as over the 21st week here, sort of here in terms of quantifying it, and less than 1% of abortions occur beyond 21 weeks, and 90% occur in the first trimester, really early in pregnancy, and 2/3 occur less than 8 weeks. So we're talking about really, really early in pregnancy that people are able to access abortion or need to do access abortion.
And it's important to point out that this data is from, I think, 2016. And because of many of the abortion bans that are put in place, some of these gestational ages are shifting towards later in the first trimester or after the first trimester because patients have to coordinate care, travel for care, save up money for care. And so that pushes them further into their pregnancy when they're actually able to get the care that they need. So abortion is common. Abortion is most common in the first trimester, and abortion is safe.
So you are 14 times more likely to die carrying a pregnancy to term than you are having a first trimester abortion. And that's a really common myth that we hear frequently, see frequently, and that people commonly believe, the research shows. And it's much less risky than other medical procedures, but also other things you do in your daily life. So a lot less risky than driving a car.
Yeah. And so there are a couple of very common myths that are perpetuated. One myth, like we mentioned, is that it's unsafe, and another myth is that it leads to infertility. And these are not true. All right. So the next part of our Abortion 101 lecture is how does abortion actually happen? And so we'll first talk about medication abortion. Actually, before we start that, when you're talking to a patient, let's say a patient comes in and they're unsure about whether or not they want medication abortion or procedural abortion, how do you distinguish the two? And what are some of the things that you talk to them about?
I feel like for a lot of these counseling discussions that I often start with asking someone about their goals and what experience they want to have. And so the experience of medication abortion and procedural abortion are different. The main difference, I think, is that in medication abortion, someone is taking a pill in the office and then taking pills at home and then having cramping and bleeding and discomfort at home. But they may be able to be in their own space that's comfortable. They can have the things that make them feel good, like their own bathroom or their own bed. They can perhaps have more support people there when they're having a medication abortion at home than they are having a procedural abortion in the office. It's also a little less medicalized. So I've had patients say that it feels more natural to them. It's more like having a miscarriage.
Right.
And then when people are having procedural abortion, I feel like the thing that people articulate is that they want it over and done with and they want certainty. Mm-hmm. And so medication abortion and procedural abortion are both really effective. So medication abortion around 98% effective, meaning that the pregnancy is expelled and that the medication abortion works. Somewhere from all but 1 in 50. So 49 out of 50 people are going to have a successful medication abortion at the gestational ages where we commonly use it. And surgical abortion or procedural abortion is, 99%, vanishingly small percentage of people aren't going to have a successful procedural abortion. It's a 5-minute procedure. It takes place in the clinic. There is some discomfort with it, but people can have various levels of pain control. And so that appeals to some people, right? They want to make sure that it's done. I think increasingly there's sort of two camps of travelers. So people who are traveling for abortion care. Some people feel like, all right, I need to get this done. I need to be absolutely done with this by the time I get home to my home state. And there is another camp of people who just happen to have to travel to get the care that they need.
Yeah. No, we frequently take care of people who travel a great distance for medications. And so, and that's their preference. They would prefer to have medication, but there is a chance that it doesn't work and then they have to travel again. And so it's all about, risk benefit for every single person is very different in how people make those decisions. It's just very different, very individualized. Ideally, it's left up to them and what they want, but sometimes there are these external factors like whether or not they have to travel, whether or not, they are concerned about bringing medication back into their state and being criminalized for that. And so it takes some of the patient autonomy out of their hands. Yeah.
Also the cost. I mean, increasingly pills are available to order online, the same pills we use in the office. We know it's safe, but I think those options are often less expensive than traveling to a clinic to get pills. And so I think that pushes some people to self-manage or manage via telemedicine when it's unclear, but some of them might prefer to be seen in clinic. Some of them absolutely wouldn't, right? They want to do this privately, but I think people should be able to access the care that they want when they want it.
Absolutely.
Anything else I sort of derailed us on the travel thing, but anything else you add when you're talking with people about preference for procedural versus medical?
No, I mean, I just, say that neither one is, I don't direct people to one or the other. I definitely defer to what they prefer. And sometimes for patients with a history of trauma, they may prefer a medication abortion to avoid an exam or a procedure. And so everyone is so different in the reason why they pick one or the other. So as far as medication abortion goes, it's a combination of two medications, mifepristone that's taken on the first day, misoprostol on the second or third day is used. And so the mifepristone prepares the body for the misoprostol to be more effective, to cause the contractions of the uterus, to open the cervix and push the pregnancy tissue out of the body. So very similar to a miscarriage. And we've talked about how you really can't distinguish whether or not someone's used medication for an abortion or is having a spontaneous abortion. We give patients medications for cramping, for nausea, and there are very few situations where a patient is unable to use medications for medication abortion, like other medical conditions that could be contraindicated. But for most people, it's safe. And despite the widespread misinformation about mifepristone, it's an incredibly safe medication to the point where I will often tell patients, listen, you may not feel any side effects from this medicine. And people are sometimes worried that, is it really working if I'm not feeling side effects? If, all this news media has said how dangerous it is. It's safe. It's a safe medication.
So I notice antibiotics is starred on this slide. I'll acknowledge it's my slide. But I'm going to ask you the question, why is it starred?
So for a while, we were giving prophylactic antibiotics for medication abortion, but really the evidence doesn't support giving prophylactic antibiotics. And in fact, there are, more instances of patients experiencing a side effect or an allergy to a medication, an antibiotic medication, rather than getting a benefit from that medication.
It just underscores how safe it is in my mind.
Yeah, exactly. Yeah, I mean, we don't routinely give antibiotics for miscarriage. And it's this, physiologically, it's the same process.
Yep. So mifepristone has been in the news a lot, and you just mentioned that. The medication was initially approved in the year 2000, and it is an anti-progestin. So progesterone is the hormone that supports pregnancy, and mifepristone is a molecule that binds to the progesterone receptors, and it binds with greater affinity, meaning it is more likely to make a bond and bond more strongly than the hormone progesterone itself that your body has during pregnancy. And so what it does is it ends up blocking the effect of progesterone because the molecule of mifepristone doesn't have that same active mechanism.
Yeah. And then the main way in my mind that it works is that it increases how receptive the body is to the misoprostol and makes it more effective. So it makes it 5 times more effective. And so that's, they work together as a medication team and is very, very effective, both for management of miscarriage and for medication abortion.
So they're like peanut butter and jelly.
Yes. I don't know which one's the peanut butter.
I don't care for peanut butter. So
maybe almond butter and jelly. Or in our house, it's almond butter and Nutella sandwiches. So anyway, all right, moving on. And this is just a graphic from a New York Times article where they reviewed all of the data supporting the safety of mifepristone, and it's really freaking safe. So
many studies show.
Millions of patients have used mifepristone. We're back to talk about procedural abortion.
But God, I love that that advertiser. I mean, Casper mattresses, they're so comfy.
Okay.
Just going to use that sigh. All right. Procedural abortion.
All right. So for procedural abortion, you have to open the cervix and then remove the pregnancy tissue. And depending on how far along the pregnancy is, opening the cervix part could be in the clinic that same day. So most abortions in the first trimester don't require additional medicines or procedures to open the cervix, aside from just using the dilators. But beyond the first trimester, we'll use medication to help soften or open the cervix, or sometimes we'll even place dilators in the cervix to help the cervix more slowly dilate.
And that's what is being illustrated on the pictures on the right there. So at the top, you have those metal dilators, which we can use for manual dilation. And then below that, with the strings, is this tool called a laminaria. It's actually made out of seaweed, and it absorbs moisture from the vagina and slowly opens the cervix. And so you can see an illustration of that.
Yep. And the second part of the procedure is removing the pregnancy. So if someone is early in pregnancy, all of this happens in under 5 minutes. The cervix is gently dilated and then either removed with a handheld suction device, or a suction machine is sometimes used for patients beyond kind of 10 or 11 weeks. And then for patients beyond 14 weeks, the cervix has to be dilated a greater amount as the pregnancy and pregnancy tissue is larger. And so that happens either through dilation evacuation or, to a lesser extent, more like a labor induction, kind of very similar to when people come in and give birth.
And on the, I feel like whenever I give this talk for students, that they're always surprised, and we often can hand out or pass around that manual vacuum aspirator, which is like a little syringe. And then next to it, the colored cannulas that you can see are just plastic straws that go through the cervix into the uterus and take the pregnancy out. And those, we measure them in millimeters. So for example, an 8 millimeter cannula is what you would use for an 8-week gestation. And so the pregnancies are really small at that point, and can pass right into that little syringe tool or into the vacuum aspirator.
Yep. And I don't think I have the picture of the size of the pregnancy tissue in these slides. Right? Okay. That was a Bev fail. But it's a small amount of tissue, and there's several articles online that we'll reference that show the actual size of a 5-week pregnancy versus a 6, 7, 8, or 9-week pregnancy. And it's not a lot of tissue. And I think sometimes even oftentimes patients want to see the tissue, and they're surprised with how small it is. And I think when we see things on an ultrasound screen in our minds, it's like a lot bigger than it is in reality. And so for many patients, that sort of helps them wrap their mind around kind of how much tissue or how much is there.
And also less recognizable as something that looks like an embryo even, right? Until you get to maybe 10 weeks, I don't generally expect to see anything that even resembles fetal parts or an embryo.
Yeah. And that's surprising to a lot of people. All right. So as far as safety, we talked about safety before, but complications are really incredibly rare.
The overall most common complication is just heavy bleeding, and that's what hemorrhage is. And then all the other complications are really, really uncommon. When we do any medical procedure, we do talk with people about the risks and benefits of different courses of action and the risks of a procedure. And so we talk with people about all these risks. And that's part of why the state-mandated counseling in North Carolina and in other states is so frustrating, because it implies that we aren't doing our due diligence or providing the normal high standard of care that we provide when we practice medicine. And so, we're both OBGYN, so we do many other types of procedures to abortion procedures. And I would say that my counseling for procedural abortion is very similar in terms of talking about risks and benefits. The only difference is then I have to also do that state-mandated counseling.
Right. And so I think the part that's really frustrating is that, there's this assumption that we're not doing our job or not fully disclosing everything to patients, when in fact I think we go above and beyond.
Absolutely. So we have really good data on abortion restrictions and the results of abortion restrictions. And this is a study report, which is a very large systematic review that was put together by a committee of people who were not abortion providers. These are people who are experts in interpreting evidence from the National Academies of Sciences, Engineering, and Medicine. And they studied the safety and quality of abortion care in the United States. And what they concluded is that abortion restrictions don't decrease rates of abortion. And that's what we've seen since the Dobbs decision, that abortion has increased. It increases the proportion of later abortion, so the need for people to access abortion later in pregnancy. It increases the proportion of unsafe abortion, and it exacerbates disparities in maternal health. And so when I read this report, what I get from it is that the types of restrictions that people are facing across the country right now do nothing to make abortion safer or improve the quality of abortion. All they do is make it more difficult to access.
Right. So, in summary thus far, abortion is common. Abortion is safe, whether you pick a medication or procedural abortion. And abortion restrictions just make abortions harder to get and increase disparities. Time for a few maps. All right. So we're going to do a case study of 3 different states and what it would look like to seek abortion care in those states. But first, let's go back in time a little bit. So on the day of the Dobbs leak, the map on the left shows that in every state, there was at least one provider of care or one clinic where patients could go to seek care. And then very quickly, within the next 6 months, we saw access shrivel up in all of these places. And those patients in those states where care was no longer available either didn't get care or had to travel for care.
Yeah. So we're going to talk about the same patient, but we're going to pretend that patient is presenting for care in 3 different states. And so this patient is 32 years old, and she is pregnant, or, well, in this case, she is pregnant. Let's say that she's around 17 weeks gestation, so into the 2nd trimester. And she presents to labor and delivery because she's had fluid leaking from her vagina. And when she has an exam, it confirms that she has broken the bag of water around the pregnancy, that she has a rupture of membranes. And the ultrasound shows that there's no fluid around the fetus. And that's a condition that we call anhydramnios. This is a really risky situation for both the person carrying the pregnancy and, unfortunately, is a very poor prognosis for the fetus. So the person carrying the pregnancy, the body is pretty good at protecting you from infection when you're pregnant. But the part of that protection is that bag around the pregnancy. And once that bag is ruptured or open, then it's very easy for infectious organisms, bacteria, to travel up through the cervical canal and infect that fluid cavity or the fluid around the fluid, or infect the pregnancy. And that's a really dangerous situation for the person carrying the pregnancy. It can mean that they have really heavy bleeding. It can mean that they have a life-threatening infection. It can mean that they end up in the intensive care unit, that they need a hysterectomy. And so the obstetric standard of care in this case is to offer to empty the uterus. And that could be with a dilation evacuation procedure, an abortion procedure, or it could be through an induction, a labor induction, where we give them medicines to help them expel the pregnancy on their own.
Right. And so it's not only dangerous to the person carrying the pregnancy, but amniotic fluid is actually critical for lung development for the fetus. So amniotic fluid is fetal urine. Fun fact, if you didn't know that already. And the fetus practices breathing in this amniotic fluid, and that helps the lungs as the fetus continues to develop later in the 2nd and 3rd trimester to develop functioning lungs. And so if you lose your amniotic fluid at this early gestational age, even if you make it to quote unquote viability, often there's not enough lung development that's occurred for those infants to survive. All right, so we're going to go to Oregon first and see what happens to this patient. So 32-year-old at 17 weeks breaks her water, and she's in Oregon. So
I did my residency training in Oregon, and that patient has no barrier to receiving immediate care. They're counseled in the setting that, so let's say they're on labor and delivery, they'd be counseled, they'd be offered a dilation evacuation procedure or a labor induction, depending on what they wanted. They could choose to have outpatient or inpatient care, and they would have no barriers to that care because both Medicaid and private insurers cover abortion, or Medicaid definitely covers it, and private insurers cover it with much more frequency there. And so the patient has all kinds of choices and immediately is able to access care.
Right. And it doesn't matter if this person lives in a city or even a more rural area, there are providers throughout the state that provide this care, correct?
Still get transfers, so there's still that problem
Still
a little bit.
transfer.
But yeah. But I think,
You have more options.
Sure, yeah, definitely have more options.
And even if you are an undocumented immigrant, you would still have insurance coverage for care. So why don't we all move to, Oregon's great, right? I also love Oregon, but let's say we're in Georgia. So patient breaks their water, 17, 18 weeks, and you're in Georgia.
So in many settings, they'd only be able to have care if they were symptomatic. And so we know that they're at high risk once they've broken their water and they present for care. But oftentimes there's a lag before those symptoms develop, before they become infected, before they start bleeding, before maybe they go into labor. And I think in many settings in Georgia, from talking with providers there, they are not able to intervene immediately. They have to wait for those symptoms to onset. Or if they're going to provide care before that, they may have to get hospital approval or an ethics consultation, which delays the patient. But we've cared for many patients who came from Georgia who were sent home to sit in the parking lot or to go home and wait for symptoms to develop and then told to come back. And that's really just a nightmare scenario.
Yeah. I've talked to providers in other access states near Texas, and, they describe, hearing stories of patients who are told to go get an adult diaper, hop on an airplane, and just hope you make it to whatever state you're going to.
Yeah. And Dr. Allison talked about that in our Texas episode. The other thing that is funny, and I meant to mention this on the Oregon episode, was I've talked with providers from access states that don't have those barriers about what they do in these situations, just to confirm that I wasn't crazy. And I think they didn't even understand the question I was asking in many cases. They're like, well, what do you mean? Of course this is what you do, right? And so it's just been that big a sea change in the way that care is able to be provided in these restricted states.
Right. And we're going against what is written in the textbooks.
Yep.
All right, let's go to Idaho.
So Idaho's probably the most extreme example, where people may not even be able to access emergency abortion care and frequently would need to be shipped out of state to be able to get care from Idaho hospitals because of how stringent and strict the law is and how it criminalizes providers.
Yeah. So there are many stories of providers talking about their frustrations, some leaving the state, and just creates larger maternity care deserts.
Yeah, and so maternity care deserts are places where there aren't OBGYNs in hospitals, maybe in a whole county. And so imagine presenting to a hospital with an emergency condition, right? Something's going wrong with your pregnancy. There are people living in those counties, and people in those counties get pregnant, and then having no one to care for you.
Yeah. We talked about some case studies in different states, and that sort of leads us into our next topic of what happens when abortion care is denied. And so we know from the Texas data, and we've talked about this before on the podcast, that when you wait for people to get sick, they get sick and have higher rates of blood transfusion, infection, admission to the intensive care unit. It's problematic without good neonatal outcomes.
And right, I mean, in this particular study, 27 of 28 of the babies involved from these pregnancies had died at the time of publication, and the last one was very ill in the intensive care unit.
Yeah, so it's forcing people into this waiting game where no one wins. And so one of our favorite studies is the Turnaway study, and the Turnaway study was conducted by Dr. Diana Green Foster, who is the lead investigator on the study. And she was really inspired to ask this study question because one of the Supreme Court justices on a case was talking about how there wasn't data to understand what happens when people didn't get care. And so she created this very elegantly designed study to understand and compare groups of people that were seeking abortion care. And so she compared people that were seeking care in the first trimester and in the second trimester. And then people who were living in states and were sort of matched to those other groups of patients, but were just shy of like the deadline to get care in their state, like maybe 1 or 2 days over the gestational age limit. And so they were turned away from care. And so she looked at these groups of people and followed them over 5 years to see what happened.
The hard thing about studying this is that, the gold standard for science in medicine often is something called a randomized controlled trial, where you take 2 conditions and you randomize people to either have that or not have that. And this is a case where you just can't ethically randomize people. But effectively, people were randomized in this situation, right? They presented and they either were just above or just under that gestational age limit and could get care. And prior studies that are bad and had come up with different answers about what happens when you can't get abortion had often compared groups that weren't the same. So groups that maybe had a miscarriage versus had an abortion, or groups that continued a pregnancy and versus someone who had an abortion, or were planning to continue a pregnancy versus someone having an abortion. And those groups just aren't the same. You can't look at them the same way.
Yeah. And so in this study, which Dr. Green Foster is going to talk about, really was able to compare those groups in a meaningful way. And some of the key findings of the study were that women who were turned away from care were more likely to stay with an abusive partner, and were more likely to raise that child alone. Denying abortion care created financial hardship and insecurity that lasted for years. And then the financial well-being and the development of their family and their children is negatively impacted. And those who were in the turnaway group were more likely to have serious health problems when they were giving birth.
So just to summarize, so we've shown that abortion is common, talked about that abortion is safe. We've talked about how restrictions are bad and cause increased health disparities, and also that they change the type of care that you're able to get, not only for someone who wants an abortion for other circumstances, but also in emergency settings. And here we know that there's a broad array of health, social, economic ill effects of denying someone abortion.
I think that's a pretty good lecture.
Gosh, we're good.
The only other thing I added to our talk is that we've been involved in a lot of advocacy around access to abortion, and sometimes we get pulled into these conversations of like, well, just make a list of the times when it's okay to have abortion care. And that, being asked those things or being made, like those requests really make us uncomfortable. And we were really able to frame it in a way that, it makes us uncomfortable because it's unethical to make a list of exceptions, because how am I to decide what things go on the okay list and what things don't? And I think it should really be at the individual level, at the patient level, to decide when care is right or when care is not right for a person. All right, we've summarized multiple times, but just to summarize one more time: abortion is common, abortion is safe, whether it's medication or procedural abortion. Bans on abortion make abortion less safe, and your zip code dictates access to safe care and whether or not you're turned away from care.